Hello and welcome to our assignment today. Today we're looking at the digestive system. Digestive system. This is a system that is made up of the GI tract, the gastrointestinal tract, and sometimes it's referred to as the gastrointestinal system. Right? This GI tract is also referred to as the digestive tract. And then now the digestive system is made up of this tract, the GI or the digestive tract, in addition to accessory organs like the liver, the pancreas, the gallbladder, appendix, and so on. The GI tract is just a series of hollow organs that are usually joined in a long, twisted tube from the mouth to the anus, right? From the mouth to the anus. That is the tract. Then we can add these other accessory organs to make up the digestive system. So the main essence of this system is to carry out the process of digestion, and digestion usually starts as soon as food enters the mouth. So we must have the teeth to be present, and they should be in a healthy state so as to help tear and grind the food. We have the autonomic nervous system, which stimulates the submandibular, the parotid, and sublingual glands, and this one are meant to produce saliva. Saliva is so key in digestion in that it helps lubricate and helps move the food and even the bacteria in the mouth, and also assists in swallowing. The parotid gland also contributes to digestion by releasing an enzyme by the name salivary amylase. This enzyme normally initiates the breakdown of polysaccharides into shorter chain. All right. Lastly, for this case, we normally produce around 1 to 1.5 liters of saliva per day. If a patient is presenting with dry mouth and they are not able to produce the same, then in clinical practice we can encourage them to suck on a hard candy, and this will help stimulate the salivation. From the mouth we go to the pharynx, and this is the second part just after the mouth. So this pharynx prevents food from entering the trachea when you are swallowing, and this is done by closing and sealing the trachea. The pharynx is divided into three sections. We have the oropharynx, the nasopharynx, and the laryngopharynx. Guys, a link will be popping up on pharyngitis. You can be able to review and understand pharyngitis better. Now, from this point, the pharynx, we have now a new process that will be going on in the digestive tract, and that's peristalsis. So peristalsis begins from the pharynx, all right? And this is simply the process by which we have esophageal muscle contraction and relaxation, and it's starting here at the pharynx, and it will help move the food during the swallowing. Next, we have the esophagus. So the esophagus is it originates at the hypopharynx and attaches to the stomach below the diaphragm. It is smooth, tubular, muscular tubular without cartilage, and it's about 1 inch in diameter. It lies behind the heart and shares a common wall with the posterior trachea, okay? And that's why we could have transesophageal fistulas, okay? The TEFs, because they do share that posterior wall, okay? Guys, a link will be popping up on transesophageal fistulas. You can review that. So the esophagus has two sphincters. We have the upper and the lower. So the upper, which is the hypopharyngeal sphincter, prevents air from entering the esophagus, while the lower one, which is the cardiac sphincter or the gastroesophageal sphincter, also This one prevents reflux of food or gastric contents into the esophagus and controls food moving into the stomach. Guys, in case this mechanism of preventing reflux of food and gastric contents into the esophagus fails, then the patient can develop gastroesophageal reflux disease for that case. Stomach is our next organ, and here is where you have now the masticated food moving down the esophagus to the gastroesophageal sphincter into the stomach. And this stomach is divided into 4 sections. First of all, we have the proximal end, which is referred to as the cardia, followed by the fundus, which is the above here, it's superior here, and it's normally found left of the cardiac sphincter. This is followed by the third section, which is the largest, and this is the body or the midsection of this organ. And then lastly, we have the antrium. And this antrium, this is where the body narrows to meet the pylorus. Okay, it is the distal end of the stomach. Okay, just after that, now we have the pyloric sphincter, then we shall get into the duodenum, right? So the stomach secretes around 1.5 to 3 mils of gastric juices per day, and the pH ranges between 2 to 3. Thank God, this is attributed to HCl, hydrochloric acid. So these gastric juices will mix with the food to create a semi-fluid state that we commonly refer to as the chyme. So the chyme will move through the stomach, through the pylorus into the duodenum. We have layers of the stomach, right? And the stomach has 4 major layers, starting with the mucosa, then submucosa, muscularis, and serosa. For the submucosa, this one is the innermost layer of the stomach. It receives majority of the blood supply and is predominantly made up of folded muscles that expand as the stomach fills. In this mucosal layer, we have a component we refer to as the lamina propria, and this lamina propria contains lymphocytes that do provide the immune response of the gut. Second, after mucosa, we go to submucosa, and this submucosa contains connective tissue, elastic fibers, blood vessels, lymphatic vessels, and the nerve plexus. Then from there we have now the muscularis, and muscularis consists of 3 layers of smooth muscles that will extend from the fundus, which is the superior part, to the distal part, the antrium. Part of the stomach. Lastly, we have the serosa. This one is the outermost layer. It's composed of squamous epithelium tissue. So narrowing down to the mucosa, we have the epithelial mucosa. The epithelial cells of the gastric mucosa have a variety of important cells, and all these cells serve as a protective barrier. So we start with the mucosal cells. These cells are responsible for producing, secreting mucus, which is very important in lubricating and protecting the stomach lining. They also produce a fluid containing bicarbonate, and this bicarbonate will help neutralize hydrogen ions due to the presence of the HCl. Mucosal cells also synthesize prostaglandins. Prostaglandins in addition to unsaturated fatty acids, and this helps prevent gastric secretion by blocking histamine from stimulating the parietal cells. So remember, the histamine has to stimulate parietal cells to release gastric acid. So prostaglandins will try and block that. Mucosal cells are in continual process of sloughing and being replaced continuously. The other type of cells in the epithelial mucosa are the parietal cells. These cells do secrete intrinsic factor. Intrinsic factor is very necessary for absorption of vitamin B12. Okay? G cells are the next, and this one are found in the pylorus glands. G cells normally secrete gastrin hormone. So, and this is secreted when protein is present in the stomach. So gastrin will increase gastric flow to facilitate stomach emptying. It also stimulates replication of mucosal cells. G cells also secrete a hormone. We have the ghrelin, and this hormone ghrelin is an appetite stimulant. So this one will stimulate and is very important in controlling hunger and satiety, which all these are normally picked up by hypothalamus in response to these two hormones, ghrelin and leptin. So ghrelin is produced by the G cells in the stomach, and it will travel to the brain to signal hunger and eventually turn off satiety. So ghrelin also plays a role in insulin sensitivity. In the stomach, you find that ghrelin will act with histamine to stimulate the parietal cells to secrete hydrochloric acid to lower pH and to kill bacteria. Ghrelin also stimulates chief cells. These chief cells will secrete pepsinogen, which in the presence of acid will become active as pepsin to digest protein. Ghrelin also stimulates gastric emptying and has a variety of positive effects on the cardiovascular functions. For example, they increase cardiac output. So these effects may direct or indirect, possibly resulting from ghrelin ability to stimulate growth hormone secretion. The second hormone is leptin, all right? So leptin is normally produced by fat cells, and it just tries to signal satiety to the hypothalamus. And when it does this, it will inhibit hunger. So we have these obese people. You find that obese people will have many fat cells, so it means their leptin levels will also be high. So high leptin in combination with high insulin will inhibit the stomach cells from producing ghrelin. But over time, high leptin reduces satiety sensitivity in the hypothalamus, and low ghrelin will increase ghrelin sensitivity. So this means hunger signals stay turned on and satiety signals stay turned off. So what about the blood supply to the stomach? We have the celiac artery and superior mesenteric artery supplying blood to the stomach. For the venous drainage, we have the splenic and gastric veins, which in turn drain the whole GI tract. On innervation, we have the sympathetic, parasympathetic, and enteric components of the autonomic nervous system. These they will do innervate the stomach and also impact gastric motility. For the sympathetic, we have sympathetic fibers that do arise from the celiac plexus. In concert with the fat and the adrenal hormones in the stomach, the sympathetic will inhibit GI activity. Also, we have anxiety, pain, emotional distress also may slow gastric motility. For the parasympathetic division, we have the fibers that arise from the vagus nerve, and they enhance GI function by increasing glandular secretions and muscle tone. So we have the enteric which is the third one. Remember, we talked of the sympathetic, parasympathetic, and enteric components. So for the enteric nervous system is the stomach intrinsic network of innervation. It functions independently from the CNS, all right, unlike the other two. And this will influence stomach secretions, muscle tone, and gastric motility. From the stomach, we go to the small intestines. So we have a tube running from the pylorus, which is the end of the stomach, to the ileocecal valve, where it joins the large intestines. It's about 23 feet long and is divided into three sections. We normally talk of DJI. Okay, DJI. All right, so the first one is the duodenum. It's approximately the first 12 feet of the small intestine. Then next we have the jejunum, all right, and the jejunum counts for about 8 to 9 feet after the duodenum. We have this transition between the duodenum to the jejunum, all right? And this place is normally affected by one common pathology that we refer to as active bleeding. Active bleeding is likely to occur between the transition between the duodenum, which is the end of the foregut, to the jejunum, the beginning of the midgut. Okay, the third component of the small intestine is the ileum, and this is the final 12/5 of the small intestine. The small intestine first digests by breaking large nutrient components into smaller ones. Then it reabsorbs nutrients as food molecules move into the bloodstream and are transported to other organs for further digestive breakdown. We have enzymes amylase, trypsin, and lipase, which function in the breakdown of nutrients for absorption. So enzyme amylase, enzyme trypsin, enzyme lipase. So hormones such as motilin, secretin, and cholecytokinin work to affect the secretion of gastric enzymes, also stimulate or inhibit gastric motility. Looking at the anatomy of the small intestine is just compared to other parts of the GIT, in that it has the mucosa, the submucosa, the muscularis, and the serosa. So the mucosa layer will receive most of the blood supply to facilitate nutrient absorption. In we have the epithelial cells, which are villi, finger-like projections that cover the epithelial layer, and this one is just to increase surface area and enhance absorption. Within the mucosa, we also have the lamina propria, and this lamina propria contains lymphocytes which function in the immune response of the gut. The submucosa will be made up of a network of connective tissue, elastic fibers, blood vessels, nerves, and lymph system. Muscularis for, for the intestines produces involuntary motility and peristalsis to move intestinal contents forward. Lastly, the serosa is the outer layer that maintains the position of the intestines in the abdominal cavity. As for the blood supply and innervation, the arterial blood supply to the small intestines is through the celiac artery and the superior mesenteric artery, just like the stomach. While for the venous drainage, the vein is through the superior mesenteric vein and the splanchnic bed. We find for the extrinsic innervation of the small intestine is just the same like the stomach. The intrinsic innervation function to stimulate motility. Muscle contractions in the small and large intestines will mix the chyme and the digestive juices, and then will facilitate nutrient absorption and move the mixture forward. So we have two types of contraction. We have peristalsis and segmentations. So when the ileum distends, it stimulates the ileogastric reflex to slow gastric motility so it can empty. Distension of a section of the small intestines will trigger intestinal reflex, and this will inhibit motility of other portions of the small intestine. The gastroileal reflex will stimulate contraction in the small intestines. What about the large intestines? So the small intestines empties into the large intestine, and it is done at the ileocecal valve. This ileocecal valve is found in the right lower quadrant, right? The right lower quadrant. You can see the place. So the ileocecal valve is between the ileum at the end of the small intestines and the cecum. The appendix will attach to the cecum, right? Okay. So the anatomy of the large intestines comprises of four sections. We have the ascending colon, right, which extends from the right lower quadrant to the hepatic flexure, right? The hepatic flexure is here. Okay. And then we have now the transverse colony. The transverse colony extends from the hepatic flexure to the right to the splenic flexure on the left, right? The splenic flexure on the left. Thirdly, we have the descending colon. It extends from the splenic flexure down to the left side of the abdomen. And then lastly, now we have the sigmoid colon, which begins at the left lower quadrant and it empties into the rectum and exits the body at the anal canal. So we have the ascending colon, transverse colon, descending, and lastly the sigmoid colon. So, what is the major function of the colon? The colon must reabsorb water, vitamins, and electrolytes, break down cellulose, and eliminate fecal material. It relies normally on the present anaerobic bacteria. So this anaerobic bacteria will decompose any remaining indigestible materials, synthesize some of them of the vitamins, and convert urea salts to ammonium salts and ammonia, which will be transported to the liver for detoxification. Okay. So we have also layers of the large intestines, and more or less the other parts have this mucosa, the submucosa, muscularis, and serosa. So the inner layer of that's the mucosa, is made up of epithelial cells, and this one will produce mucus, which will help move the fecal matter along the intestine. This mucosa also helps reabsorb water, so the majority of blood supply goes to the mucosa when compared to these other parts. All right. Okay. What about innervation? The blood supply. Okay. We have the superior and the inferior mesenteric artery branches which supply to the large intestines. Equally, we have superior and inferior mesenteric veins which will drain into the portal system of the liver. In terms of innervation, we have sympathetic and parasympathetic fibers which do innervate the large intestines. So stimulation of the sympathetic will inhibit motility through the large intestines and contract the anal sphincter to prevent defecation. While stimulation of the parasympathetic will increase motility and will also lead to relaxation of anal sphincter, and this allows defecation. Other factors that stimulate intestinal motility are bacterial endotoxins, viral infections, enteritis, ulcerative colitis, increased bile salts, osmotic overload, and laxative. So motility is decreased by low bulk diet, parenteral nutrition inactivity, dehydration, fasting, and medication. Common pathology that will be associated with the colon is the diverticular diseases. All right. Okay. So we have generally GIT defense mechanism. You find that there are around 5 primary defense mechanisms that maintain the integrity of the GI tract. So if any of these fail, we could have potentially pathogenic bacteria that can translocate from the GIT into the bloodstream. So the first barrier, we have the mucosal barrier. This provides both physical and mechanical barrier to substances such as hydrochloric acid so as to prevent ulceration. GIT motility, this prevents bacteria from moving backward to the GI tract and moves pathogens out of the body. We have the gut immunity, which is consisting of the lymphocyte macrophages, especially in the lamina propria of the mucosal layer, will protect the gut from the potentially harmful bacteria. Gastric acid will maintain, so the gut will maintain an intragastric pH of about 4, just to protect the stomach from ingested bacteria and prevent bacteria from entering the intestines. Lastly, we have the gut flora, and this one compete with pathogenic bacteria for nutrients and attachment sites. So we have the peritoneum. And this is a two-layer serous membrane that normally lines the abdominal cavity. It also covers most of the intra-abdominal organs. We have the mesothelium layer, which is supported by a thin layer of the connective tissue. So the peritoneum supports the abdominal organs and serves as a conduit for blood, lymph vessels, and nerves. So infections by the peritoneum can lead to infections like peritonitis, where we have fecal matter and purulent material present throughout the abdomen. You could compare this to the normal or the healthy one, right? So the peritoneum serves as a semi-permeable membrane, predominantly as a passive semi-permeable membrane, and this will allow bi-directional flow of water and most solids. So theories identify the number of small and large pores and local blood flow as the factors that will dictate the fluid exchange and solute flow across the peritoneum. So while the entire peritoneum is semi-permeable membrane for fluids and solutes, the passage of this particulate matter such as bacteria is restricted, and under normal circumstances they may only occur in certain locations, right? Okay. So from there we can now look at accessory structures, right? These are just structures that do aid digestion physically and produce secretions that break down foodstuff in the GIT. So the accessory organs could include the teeth, the tongue, the glandular organs such as the salivary glands, then not forgetting about the major ones here, the liver, the gallbladder, and the pancreas. Starting with the liver, this is the largest semi-solid organ, right? And it's located in the right upper quadrant, just under the diaphragm. It's about 3 to 4 pounds and is a soft and semi-solid structure. The liver is divided into right and left lobes, right? So you find that the right lobe is 6 times larger and is divided into quadrate and caudate lobes. So each lobe is consisting of lobules or dysfunctional units, right? Okay. In terms of blood supply, you find we have the hepatic artery and the portal vein that will be entering at the hilum and deliver approximately 25% of total cardiac output per minute. So, hepatic artery will account for about 25% of the volume, while the portal vein, right, the portal vein, this one will account for 75%, right? This is 25, this is 25, right? Okay, remember hepatic is direct branch actually from the celiac artery, right? Getting into that, right? But the portal vein has to drain this other part, right? We can be able to see that. So both the liver blood by branching into sinusoids and encompass the liver cells. We have the Kupffer macrophage cells in the liver, which line the sinusoids and filter bacteria and foreign substances from the blood. Blood will be exiting the lobules through the central veins and then collect into hepatic veins, and then lastly this will drain into the inferior vena cava. You can be able to see that. So we also have another function of the liver, that is bile drainage. So the bile drainage system starts at the canals in the sinusoids, the ones that we are referring as the canalcules. So it drains through a system of small ducts, which eventually connects to form the right and left hepatic ducts, right? You can see the right and the left, right? So the right and left, they connect to form common hepatic duct. Then the common hepatic duct joins with the cystic duct to form the common bile duct. The common bile duct will join with the pancreatic duct, okay, and they'll join at the ampulla of Vata, where we have the sphincter of Oddi, right? The sphincter of Oddi, right? So you start with right and left. They join to form common hepatic duct. The common hepatic duct joins with the cystic duct from the gallbladder, to form the common bile ducts, and the common bile duct will now join with the pancreatic duct at the ampulla of Vata, where we have the sphincter of Oddi. So on physiological function, the liver is responsible for more than 400 physiological functions. And some of the primary functions include metabolic function, synthesis, detoxification, and bile production. On metabolic function, the liver breaks down carbohydrates, proteins, fats into nutrients, and then will synthesize and transport and store them. It converts excess carbohydrates into triglycerides for energy and storage as fat, and also facilitates the storage of fat-soluble vitamins, vitamin A, D, E, and K. It also stores vitamin B12, copper, and iron. The liver synthesizes albumin and other plasma proteins to help maintain oncotic pressure within blood vessels. On synthesis, the liver synthesizes clotting factors, including fibrinogen and prothrombin, which are very essential for blood clotting process. We also have Kupffer cells, which normally clear blood of all red blood cells by releasing bilirubin, which the liver cells then conjugate for excretion. On detoxification, we have hepatocytes. These are liver cells. They will detoxify the blood by metabolizing or by transforming drugs, hormones, or other toxic substances. The liver normally produces around 600 to 1000 meals of bile per day, and this bile will aid in digestion, absorption of fats. Normally, bile consists of bile salts, cholesterol, bilirubin, electrolytes, and water. Next, we have the gallbladder. It is about 3 to 4 inches. It is sac-like structure attached to the inner surface of the liver. The bladder has a cystic duct that normally joins the hepatic duct from the liver to form the common bile duct. Right? So the bile will move through the system of ducts through the sphincter of Oddi into the duodenum. The sphincter of Oddi is the one responsible for controlling bile flow rate and also prevents reflux from the duodenum into the pancreatobiliary system. Okay. So we have a hormone cholecytokine, and this one is normally released when chyme is in the duodenum. So it will stimulate the gallbladder to contract and the sphincter to relax so as to release the bile. The blood supply, we have the hepatic and cystic arteries supplying the gallbladder. Blood drainage is through the cystic vein. The gallbladder is innervated through the splanchnic nerve. The primary function of the gallbladder is the concentration and storage of the bile. Bilirubin is the main pigment of this bile pigment. So any obstructions in the bile flow will result into elevation of direct bilirubin concentration in plasma. The next accessory organ is the pancreas, which is a large gland and it's about 6 to 8 inches long. The head of the pancreas sits in the curve of the duodenum, right? Sits in the curve of the duodenum. The body extends behind the stomach, while the tail will touch the spleen. Okay, so we have the spleen here. So then we have the duodenum here. So the head of the pancreas can be able to see it is just resting on the duodenum, right? So ducts from each of these units will pump their secretions into the duct of Waring, and this duct of Wasson is what we refer to as the pancreatic duct, okay? Pancreatic duct. So this duct will then join the common duct at the ampulla of Vata, which is normally surrounded by the sphincter of Oddi. So the sphincter of Oddi will be controlling the release of these contents to the duodenum. In terms of blood supply and innervation, find this: we have superior, mesenteric, and ciliary arteries supplying blood to the pancreas. The portal and the splenic nerves will drain it. innervation, we have both branches of the autonomic nervous stimulation, which will be innervating the pancreas. So the sympathetic division will decrease pancreatic secretion, and the parasympathetic or the vagal response will stimulate secretion of these pancreatic secretions. All right. So we have digestive hormones in the intestines, which will also regulate this secretion of this pancreatic juice. So the pancreas also serves exocrine functions, and the primary exocrine function of the pancreas is to secrete enzymes that will aid digestion. So the pancreas normally secretes about 1.5 to 2.0 liters of pancreatic juice per day with an alkaline pH of range of about 8. This juice is composed of bicarbonate, water, sodium, potassium, and digestive enzymes. Remember, bicarb is very important for neutralization purposes. So we have enzyme trypsin, which will digest proteins, and also have amylase, which will digest starches, glycogen, and other carbohydrates. And last, we have lipase, which will be digesting the fats. So the pancreas also produces substances that will inhibit its auto digestion, all right, by its own juices. Next, we have the appendix. All right, the appendix is usually located in the lower right quadrant of the abdomen near the right hip bone. So you find the base of the pancreas of the appendix is located 2 centimeters beneath the ileocecal. Okay, and this ileocecal we know is the one that separates large from the small intestines. All right, large and small intestines separated by the ileocecal valve. The major function is just housing and cultivating beneficial gut flora that can repopulate the digestive system following an illness that normally wipes out normal population of this flora. We could have a burst appendix, and this could result into peritonitis. Okay, somebody who is suffering from appendicitis, okay, which is one of the common pathologies associated with the appendix, will have the positive McBurney sign. Positive McBurney sign is when there is significant pain is elicited by palpating the right lower quadrant, right? The right lower quadrant. Okay. Okay. So we have several disorders that are associated with this digestive system, and the top 11 which are commonly tested. We have the acute bleeding, GI bleeding, gastroesophageal reflux disease, peptic ulcer disease, pancreatitis, appendicitis, peritonitis, the Crohn's and ulcerative colitis, diverticular disease, celiac disease. We have intestinal obstruction, and lastly we have the cholestasis, the one that is caused by gallstones, or referred to as the cholelithiasis, right? Let's look at some of them, starting with the peptic ulcer disease. And this one is here, that is characterized by development of circumscribed lesions in the mucosal membrane of the lower esophagus. Okay, you could have in the lower esophagus, or you could have in the stomach, duodenum, or jejunum. So we could have many types of peptic ulcer. Okay, we could have esophageal, gastric, or duodenal, but the main forms are two. We have the duodenal ulcer, which accounts for about 80%, and the gastric ulcer, or both chronic. Okay, so the duodenal ulcer will affect the proximal part of the small intestines and follow a chronic course characterized by remissions and exacerbations. Complications that necessitate surgery will occur in about 5 to 10% of patients. Gastric ulcers, on the other hand, will occur in the stomach lining, and they are mostly caused by one bacteria. We refer to it as the H. pylori, the Helicobacter pylori infection. Okay. So the duodenal ulcer, the patient will present with pain. Usually it will be occurring like 2 to 3 hours after food intake, and it will be relieved by food antacids or antisecretory agents. This pain can awaken a patient, right? Gastric ulcer, on the other hand, is associated with recent weight or appetite loss. Patient will be nauseated, vomiting. This pain is worse at night and early in the morning. Pain may be relieved by food, antacids, or vomiting. The pathophysiology of peptic ulcer disease is more associated with H. pylori, Helicobacter bacteria, Helicobacter pylori bacteria, which normally releases toxin, and this toxin promotes mucosal inflammation and ulceration. So with a peptic ulcer resulting from the H. pylori, the acid may not be the dominant cause of bacterial infection, but it will contribute to the consequences, including high levels of gastrin, pepsinogen, and reduced level of somatostatin. We have duodenal bicarbonate secretion may also be impaired. Remember, the duodenum normally produces some bicarbonate that is responsible for lowering the pH. So this could also be impaired. So this will lead also to acid injury. Okay, and this can affect also the duodenum. So ulceration stems from inhibition of prostaglandin synthesis, increased gastric acid, pepsin secretion, reduced gastric mucosal blood flow, and reduced duodenal bicarbonate secretion. They have decreased cytoprotective mucus production. Of course, causes we have said H. pylori, which accounts for 90% of duodenal ulcers and 70 to 90 of gastric ulcers. We also have the use of NSAIDs or glucocorticoid use and pathogenic hypersecretory states. Also, genetics is also associated. Risk factors include blood type A, especially for gastric ulcers. Individual studies have shown individuals with type A blood group are likely to be very irritable, and this predisposes them to releasing more HCl, right? That predisposes them to this. Type O, blood group O, are also at risk of duodenal ulcers, and this is because they do stomach a lot for that case. Gastric or duodenal mucosal defects, pressure to irritants, cigarette smoking, high stress, family history, psychogenic factors, use of NSAIDs, normal aging, also family history are also associated with peptic ulcer disease. In terms of incidence, most peptic ulcer occur in the ages 25 and 65. However, the incidence of bleeding ulcers is 13 times higher in people over 70 years. Approximately 4.5 people are affected each year with peptic ulcers, and male and females are affected equally, but the incidence it will increase with age. So complication could be like GI hemorrhage, which occurs, which is 13 times higher in people over age 70. Ulcer penetration into structured touch structures have increased risk of gastric adenocarcinoma in patients with H. pylori, obstruction from scarring or acute inflammation, and bowel perforation and anemia. We could do some tests where we could do CBC, complete blood count, with which will show differential, which will show anemia and possibly elevated white blood cell count. Okay. Fecal occult could also be positive, or H. pylori antibody test could also be positive for that case. We also have positive fasting serum gastric levels, which will try to rule out Zollinger disease. This peptic ulcers is very similar in presentation compared to the Zollinger-Ellison's disease. So serum gastric levels will be higher in patients with the Zollinger-Ellison syndrome, and this helps differentiate the two. In terms of imaging, we could do a barium swallow test or upper GI or small bowel series, which may reveal an ulcer. or upper GI tract X-ray, which may reveal mucosal abnormalities. In diagnostic procedures, upper GI endoscopy or the EGD, ethnogastroduodenoscopy, will confirm the ulcer, will identify the H. pylori, and will determine and control bleeding and permits cytologic studies and biopsy just to rule out cancer. We also have gastric secretory studies that may show hypercholehardia. In terms of treatment, we could have treatment of symptoms or stress reduction, which are major contributors, smoke cessation, and avoiding of NSAIDs if they are the underlying cause. The diet, we have to avoid dietary irritants such as spices, alcohol, or caffeine. There should be nothing by mouth if the patient is bleeding, okay, and the healthcare provider has to be informed. In terms of medication, for the H. pylori, Helicobacter pylori infections, we could do the triple or the quadri therapy. So for the triple therapy, we have a proton pump inhibitor. It could be omeprazole, lansoprazole, or rabeprazole sodium, or esomeprazole magnesium. Then you combine it with 2 antibiotics. It could be like the macrolides, the clarithromycin, and a penicillin, amoxicillin. Or we could have a clarithromycin, this is a macrolide, and a metronidazole, okay, an azole hydrochloride. For the quadruple therapy, we need a proton pump inhibitor plus a bismuth salicylate, metronidazole hydrochloride, and a tetracycline. For the gastric or duodenal ulcer, we need a proton pump inhibitor such as omeprazole. And remember, chronic use of omeprazole can place a patient at increased risk for developing hip fracture, right? The other proton pump, we have lansoprazole, labeprazole sodium, esomeprazole magnesium, and pantoprazole sodium. So apart from the PPEs, we also have the histamine 2 receptor blockers, right? Such as the nitidine, cimetidine, and famotidine. We could also have the sucralfate or antacids and IV fluids with in complicated or GI bleeding. Okay, remember antacids have to be taken 1 or 2 to 3 hours after the meals to avoid these drug-drug interactions. The last condition is peritonitis, and this is characterized by inflammation and infection of the peritoneum, and incidence occurs equally in males and females. It could be acute or chronic, and we have it's fatal in 10% of patients, with bowel obstruction being the most common cause of death. Okay, so there are 3 forms of peritonitis. We could have primary, which is usually due to hematogenous dissemination, such as with immunocompromise, the so-called the spontaneous bacterial peritonitis. Or we could have the secondary one, which is the most common type, and is usually due to trauma, surgery, or pathogenic process in an organ. Lastly, we could have tertiary, which is characterized by recurrent and persistent infection after initial therapy. Okay? All right. In terms of pathogenesis, you find that peritonitis, you have bacteria which will invade the peritoneum. So after this invasion, this will lead to inflammation and perforation of the GI. So we have fluid containing protein electrolytes will accumulate in the peritoneal cavity. Remember, the cavity is normally transparent. So the peritoneum, in this case, it will become opaque, red, inflamed, and edematous. We have infection now will localize as an abscess, or rather disseminated, so that we have a generalized infection. Peristalsis will be slowed or sometimes even stopped. Respiratory problems can result from abdominal distension caused by fluid shift into the peritoneal cavity. In terms of diagnosis, we could do CBC, which will show leukocytosis, or blood chemistry may reveal dehydration and acidosis. Blood culture or peritoneal fluid culture will be positive for the offending organism. When you look at the serum to ascites albumin gradient, it will be greater than 1.5, especially in spontaneous bacterial peritonitis. Abdominal X-ray will show edematous and gaseous distension of the small and large intestines. Then you could have perforation of the visceral organ, where we have X-ray showing air in the abdominal cavity. Chest radiography may also reveal elevation of the diaphragm, while CT computed topography scanning may reveal intra-abdominal mass, fluid, and inflammation. MRI may reveal abscess, while ultrasonography may reveal increased peritoneal fluid levels. In terms of treatment diagnostic procedure, we could do paracentesis, which may show exudatives nature, leukocytosis, low pH, glucose levels, and elevated protein and lactate dehydrogenase levels. And this will permit bacterial culture testing, where we do a neutrophils test with a neutrophil count greater than 500. This will indicate spontaneous bacterial peritonitis. We could do general treatment where we have the NG intubation, hemodynamic monitoring, correction of the underlying conditions, venous thromboembolism prophylaxis. In terms of diet, you should have nothing by mouth until bowel function returns. Also, gradual increase in diet and total parenteral nutrition if necessary. You also have bed rest until the condition improves, and semi-Fowler's position is the best here. We need to avoid lifting of items for about 6 weeks post-operatively, right? Medication, we have broad spectrum IV antibiotics based on the infecting organism. We could have like the cefotaxime sodium, amoxiclav augmentin, and then we have also these other azoles like metronidazole for a fungal infection or the ofloxacin, right? Gentamicin sulfate for peritoneal installation. We also have diuretics like furosemide, which can help reduce ascitic fluid. Guys, a link on diuretics will be popping up. You can be able to see the classification of different diuretics. Furosemide is a loop diuretic. We could also have fluid administration, especially if septic shock develops, and electrolyte replacement as on need basis. Lastly, you have analgesics for pain and antiemetic for nausea and vomiting. Remember, surgery is the treatment of choice for peritonitis. Guys, that wraps the end of our presentation on GI disorders.